Hello, and welcome to the HSJ Health Check Podcast, where each week we discuss the very latest coronavirus news and analysis of the impact the pandemic is having on all corners of the NHS. I'm Annabelle Collins, and this week I'm joined by Deputy Editor Dave West, Bureau Chief James Illman, and Correspondent Katherine Hignett. We are recording a day after NHS England has set out a 6-week action plan and priority areas for the service as it starts to move towards restarting some non-COVID services. So this is far from completely back to normal, but trusts are now being asked to look at how they can release and redeploy capacity. So James, you covered this for HSJ yesterday. Would you be able to take us over the action plan in a little more detail, perhaps what stood out to you in particular, or even perhaps what was missing that you expected to see?
Yeah, sure. So, as you were saying, the plan was set out yesterday in a letter sent to local leaders. We know that there's a really urgent need to restart lots of services, cancer, heart, cardiovascular. We know that the slowdown in provision has already tragically cost lives and led to patient harm as a result of people missing vital appointments. Well, that's been very well publicised. But as our editorial pointed out on Thursday, the restarting of routine care will not be a simple task, and it will vary greatly region to region. So we know that plenty of acute trusts are understandably very anxious to get going again on elective work, but there's a lot of local factors to consider in terms of what to reintroduce when and at what rate. So obviously, there's the region's COVID load to take into account. So that varies a lot across the country. But then there's also factors such as the availability of blood stocks, other anaesthetic agents, which will limit the ability to resume operations. So there's a lot to take into account, and all that comes against a backdrop of concerns which have been raised both by clinicians and also by some senior trust leaders to me this week, that the NHS could be overwhelmed by a spike of attendances as the lockdown eases and patients start to feel safe to come out again. So we've seen this huge drop off in emergency admissions. We know that hospitals generally, the occupancy rates are incredibly low, and already hospitals are struggling. So you've got a service with an exhausted staff could be swamped by something similar to a winter rush, and incidentally, winter isn't actually that far away. Although it might feel like we're heading into summer, we're actually starting the planning period for winter as well. So it feels like there's a lot coming down the track, so much so that, and Annabelle, it'd be good to grab some of your thoughts on this. Some people have said to me that this, when we look back at it, this will be seen as a bit of a lull and a bit of a quiet time, and perhaps now is the time to give some staff a bit of a rest in preparation for what is, going to be a really, really tricky period, an exhausting period, as both the NHS tries to keep the COVID service going whilst ramping up all the other business as usual services against this backdrop of a lot of staff being off and eventually moving towards winter again.
No, absolutely. I think the point you make about kind of resting some staff is quite interesting. So at the beginning of this, I think the biggest concern was around staff sickness from COVID, but I think people are also acutely aware of fatigue and kind of the mental pressure that the staff are under at the moment. I think it will be quite interesting to see how, particularly some of the returners to the NHS, their future role, because a lot of people signed up to kind of go to the front line and step in during a pandemic, but that role is now starting to slightly change. We're seeing kind of more pressure on rehabilitation and community, and some senior sources sort of suggested to me that that's a much less appealing prospect for some people. People signed up to work on the front line, and if they're saying, we need somebody, I don't know, to instead work in a community trust, maybe that's less appealing.
Yeah, the adrenaline kind of runs out, doesn't it, as well?
Precisely,
From
yeah.
out of the adrenaline kind of, actually, although it's really hard, it's also quite exciting phase into the just long slog and phase.
I think that's exactly it. In that people thought we're going to come back and help out for a defined period. But unfortunately, none of this is defined, and it could go on for a really long time. And there was another point that was raised to me in terms of the logistics of running all these services in this phase 2, and that's social distancing. So Katherine Henderson, who is the president of the Royal College of Emergency Medicine, was saying that it would be unacceptable and unconscionable to go back to corridor waits and overcrowding in EDs when, you know, we're in an endemic COVID-19 world. So you can't really have people social distancing at Tesco, but then turning up at an emergency department and be packed like sardines in, you know, when there's COVID is still very much in the system. So bearing in mind how cramped and crowded A&Es have been in recent years, that's a huge challenge.
I wonder whether did she have a sense of kind of when people's behaviour might start to kind of revert back? Because obviously we've seen a huge dip in A&E attendances.
Yeah.
Is it starting to slightly pick up?
Already begun.
Really?
The kind of soft intelligence and is the admissions are creeping back already, and we haven't even had any easing of a lockdown yet. So pretty soon it feels like there's a very small window in which to think about how do we run the NHS's normal services in a socially distanced way. It's very tricky.
Dave, did you want to come in there?
Only to say that the emphasis in the letter yesterday was on phase 2, which seems to be the view to be that that's about 6 to 8 weeks, and I suppose that's as the peak, the peak hopefully continues to fall away. But as well as getting through that 6 weeks, it's what the letter doesn't really state. It surely also has to be 6 weeks to think about. Spend quite a lot of time thinking about the subsequent weeks and months beyond that, because actually some of the measures that are not set out in that letter are quite. It's perhaps worth noting one or two of the measures that are not set out in that letter that people are speaking about, like moving to completely hot and cold COVID sites. Because if the NHS is unable to move back to enough normal business, just by cohorting and trying to make the kinds of changes that James was talking about with Katherine Henderson, how do you design an A&E, a normal A&E department so that you can keep people distanced? I don't know whether if that proves to be impossible, there may need to be a move to designate particular general hospitals as COVID or not COVID,
or the Nightingales.
Like that. Well, Nightingales, the plan at the moment does seem to be Nightingales will. I mean, that's sort of the exception, along with the private sector, I suppose, because the private sector, it seems to be assumed that private hospitals will be used at least till the end of June, often as kind of cold non-COVID places, and then there's a question mark about how widely they're used from July. And then the Nightingales are. I think there's 7 or 8 confirmed, aren't they? Although only 2 of them, I think, have actually had any patients in at all. It's very small numbers. But the rest, what I asked in the press briefing on Monday about what part Nightingale's had in the recovery, and the health secretary said that for now, the assumption was that all of them would be used as some form of COVID hospital to help take the pressure off other hospitals and them getting things back to normal, which of course will be helpful, but it's slightly hard to envisage that transition taking place when they are in the most part now completely empty and trusts aren't lining up to share their staff with them.
No, exactly. I was going to mention staff. If they do want to keep the Excel on as a COVID hospital, I wonder where they're going to get the staff if the doctors and nurses who were moved out of their kind of home trust have gone back in to help with some of the normal workload.
One of the things, it's a bit of a kind of a sort of managerial interest, I suppose, but one of the things that the letter from NHS England said, and other people such as NHS providers have observed, is that they quite like the part of the way of this COVID response that's been about local autonomy and sort of trusts, trusts and some other kind of local actors can lead the way that operations are decided, rather than letting NHS England or the government try and decide everything and send the orders out. But something like that is a kind of classic case of where, well, some regional or system or national agency is going to have to, if you want to use the Nightingales, then someone's going to have to tell the system who's going to staff them. And we saw a flavour of that in London a couple of weekends back. HSJ revealed, the London regional director, saying, look, parts of London, you do need to send staff to this Nightingale hospital. However, so far, whether the staff have been sent, I don't know, but the patients don't seem to have followed.
I'd heard that they hadn't been sent, that some trusts had sent staff and some hadn't. I think it's maybe a mixed bag. So but I suppose like David Sloman would kind of have the authority to say, no, you need to send them now. So,
yeah, I don't know why that. Perhaps they're keeping the local autonomy for now, but if they do want them to be used, they may need a bit more of a regional or national stick.
And that was something that sort of struck me, I suppose, as sort of the regional focus on some of the plans in the letter. I don't know if would you agree with that, James?
Yeah, I mean, because COVID has affected different regions quite profoundly differently, there's definitely going to need to be I think about local leadership and about who leads locally. So is it going to be a lot of the kind of bigger trusts on the patch? Dame Barbara Haken was talking to our colleague Sharon Brennan a couple of weeks ago about saying that SHAs would have been a good structure in this environment. So yeah, how that local leadership comes together, how whether it's through sort of ICSs or a more sort of localized version will be quite interesting. I imagine it would differ from patch to patch, because you've got ICSs of very differing maturities and different local dynamics, but certainly there's been a strange dichotomy of quite a lot of command and control so far during COVID, but also local areas been given quite a lot of flexibility around issues like mutual aid and how to take on various things. So yeah, that kind of locally led aspect of the next phase will be pretty interesting to keep tabs on.
It was suggested to me by someone that might be more successful. They sort of said that NHS England had a command and control approach to the workforce, and kind of and particularly the kind of returner scheme, and they said that it wasn't as successful as it could have been if it had been a more regionally led initiative. So yeah, absolutely want to keep tabs on there. And I think before we move on to our next topic, just an important thing to mention as well is the kind of the focus and kind of the concern around BME staff. And our colleague Nick Catuno covered that for us yesterday as well. So basically, the letter said that healthcare leaders should risk assess staff who may be at greater risk of COVID, including those from Black, Asian and other minority ethnic backgrounds. And that kind of linked to a story we published earlier in the week as Somerset FT, which was the first trust that we heard about, categorised its BAME workers as vulnerable and at risk. And that was quite a that felt quite a pivotal moment, as obviously this conversation has been kind of rumbling on for a while, and there was sort of people saying, we don't have enough data yet. So that kind of felt like a concrete decision that a trust was kind of taking upon itself to make. Yeah, I don't know whether anyone has any thoughts about what we could see happening over the next kind of few weeks on this particular topic.
Yes, so as you said, Annabelle, the letter does underline that BME that trusts are advised to do sort of extra risk assessments and risk discussion with their BME staff about their work during the outbreak, and this follows on from massive concerns over the last few weeks as evidence has emerged that more BME people may be getting the infection and then having severe effects and ultimately dying with the infection, include BME people across the board, but also particularly NHS staff, where this has become very visible and alarming fact. HSJ, we published some analysis by some doctors which confirmed this in NHS staff, and also published a story about Somerset Foundation Trust, which I think was the first to, at least the first publicly to say it was treating BME staff as a kind of at-risk group, and therefore giving them more discussions about how they sort of extra management of their work they need during the outbreak, and it seems wise for NHS England to get on board, but also, inevitably people have pointed out, well, it's rather late now, as with a lot of stuff during this outbreak. It's moving so quickly, and it means that when interventions do ultimately come, it feels too late. The other thing that this issue does, I think, is kind of highlight is one of the examples of how the coronavirus is kind of shining a light on examples of discrimination that sort of happen throughout the NHS and other walks of life on a normal basis, but then kind of puts them in a kind of casts them in a sort of additionally terrible glare because of the effects of coronavirus. Because the kinds of things that we seem to be NHS England seems to have in mind when they're talking about these risk assessments is, are people implicitly discriminating by favouring sorts of professions who may be more white over sorts of professions that may be more BME when they're allocating PPE protection and things like that, and of course just the general balance of racial makeup in roles, senior, more junior, the kinds of things that you're asked to do, whether you feel extra pressured to do carry out tasks and do jobs that you might not feel safe doing and might not want to do, those kinds of everyday aspects of discrimination, really, which it sheds a light on.
I know, and we know that there will be I think a government has launched a BAME COVID review, led by kind of PHE's Kevin Fenton, but I don't think we'll have to wait a bit longer to hear when that will be reported. Okay, so I think we need to move on to our next topic and bringing in Katie. So PPE, this is obviously an issue of continued importance over the last few months, and I'm just hoping that you'll be able to give us kind of an update, Katie, on trust supplies. What are the key pressure points we're seeing now?
Well, I think at a trust level, there are still huge concerns over the supply of gowns. Gowns have been in the news a lot over the last month or so because supplies have become really critical, and has now been widely reported. Gowns weren't included in pandemic preparedness stockpiles, so it's something that I think is probably a factor in why there aren't that many of them around. Other products that are under particular stress are examination gloves, which are used throughout health and social care sector in normal times. So a lot of PPE, you don't necessarily use that much of it when you don't have coronavirus. In normal times, you probably wouldn't use that many gowns compared to what we use now. But examination gloves are present absolutely everywhere. You would see them at a GP, you would see them across a hospital, and obviously they're a really key part of PPE for coronavirus treatment now. So recently, the organisation that's kind of doing central procurement for trusts, they moved the category of gloves from business as usual supplies, where you would order a certain number and you'd get them to a so-called kind of push delivery service, which is where PPE and other coronavirus related products are being delivered in kind of drops to trusts. So instead of telling the procurement body how much of an item they want, trusts just kind of get a delivery of a kind of a bulk batch of this stuff. And that causes a lot of issues within a trust when it comes to examination gloves, because they don't just need those gloves in one place at a trust, they need them across that organisation. So they're sort of redistributing them themselves. And of course, that also suggests that the supply of those gloves is under extreme pressure as well. And there are also continuing issues with various types of masks, FFP3 masks and FFP2 masks, for example. There are concerns over whether there are enough of those being delivered, whether there are enough in stockpiles as well. It's probably interesting for procurement people to see how members of the public now know what an FFP3 mask is. Speaking for myself, I've learnt so much about different types of masks in the last few days. But yeah, those three issues still huge, among others as well. Like there are other supply pressures, but those particular products are ones to highlight at the moment at hospitals.
This might be a tricky question, so don't worry if you can't answer it, but I was just wondering whether procurement people are worried about if kind of national guidance on public mask wearing changes at all. Is that kind of a concern? Could that put more pressure on suppliers of other, non-NHS or health and social care people try and get hold of masks in particular?
Yeah, that's a good question. I think anything that puts extra pressure on the supply of those products will affect people at a trust level. So it's not something that my contacts are sort of initially reaching out to me about, but that doesn't mean it's not something they're concerned about. They just have ultimately more immediate acute concerns. However, I have been told that the price of certain masks, for example, has gone up enormously in recent weeks because of increased demand across the board, and global demand, that is, not just in the UK. It's highly, if members of the public all started buying the kinds of masks that you use in a health and social care setting, that would also obviously increase the price. And at the moment, a lot of those supplies in the UK, almost all of them will be going to healthcare settings. But I mean, I'm sure companies would see an opportunity to start selling those to the public if they thought that the demand was there. I mean, it's already happening to some degree. I think if government guidance did change, I think it's highly unlikely they would suggest members of the public buy those specific masks that you would use in a healthcare situation.
No, absolutely. Oh, sorry.
I was just going to say we can keep an eye on what's going on in Scotland for that, but it does seem people are being advised, yes, definitely do not buy clinical grade masks, and also you can just use a scarf and stuff like that. So I think there would need to be like a big public awareness campaign to make sure that didn't happen.
Yeah, absolutely. I was just going to say actually about kind of educating the public, because I've seen chat on Twitter, but seeing people wandering around the park wearing an FFP3 mask it seems a little bit over the top.
It's interesting at the moment. You see a lot of people wearing ones that you'd buy in masks that you buy in DIY stores, which look quite a lot like FFP3 masks. FFP1 masks, for example, you might buy in B&Q if you're going to insulate your loft or something. Those kinds of things that people have had lying around their houses, it is really strange to go into shops and see people in the queue behind you in one.
Absolutely, I can't get used to it. It's bizarre. But also just a couple more questions, Katie, just on PPE. But we talked earlier about elective work kind of slowly kind of starting to gradually restart, but with kind of concerns around PPE shortages, is that going to hamper kind of restarting work? I suppose I'm thinking kind of surgery in particular.
I think it will certainly have an impact, because obviously you can't perform certain procedures without the right materials there. It's just not safe. I think it's definitely worth noting that demand for PPE at a trust level and actually just generally is really, really high compared to normal, and hospitals are using much more of lots of this stuff than they would ever use in a business as usual setting. However, when you think about things like the examination gloves in particular, you can see how that huge demand is really impacting the ability of trusts to actually buy those things for business as usual circumstances. And I suspect that, especially when it comes to things like surgical gowns, if they're being used at the moment to treat for staff treating coronavirus patients, that's obviously going to impact the supply of those at a trust level. And like I said, you simply can't do certain procedures without the right stuff.
And just finally, we've kind of focused on obviously on kind of the NHS experience of PPE, but can you say anything more about other healthcare settings? I think we've seen kind of in the national media increasingly over recent days concerns around hospice staff and obviously care home staff not having adequate supply.
I mean, it's all areas of health and social care are experiencing huge pressures when it comes to getting this kind of equipment. GPs, for example, adult social care organisations, they wouldn't normally have much of this stuff in stock. They might not necessarily have particularly strong relationships with suppliers of these items. It's also one area that's really, it's kind of lagging behind in terms of the centre's own procurement and distribution. So by that I mean trusts, for example, have been getting central drops of PPE and other coronavirus related products for some weeks now. That simply isn't happening in the same way, or at least it's not happening in the way it's supposed to be happening on a community level. So although community organisations can contact a PPE hotline, for example, they also will or should be receiving drops from their local resilience forums. They're supposed to also have an online portal through which they can order supplies, or at least indicate their need for supplies on a less kind of emergency basis than the hotline. They're supposed to be able to indicate how much stuff they need, and then in theory the same central body that is distributing stuff to trusts should also be distributing to them as well, as opposed to going via the local resilience forum route. If I haven't lost you on that, basically this sort of online system, it was anticipated this would be up and running hopefully in early April. So I think it was the week of the 6th of April. This portal was supposed to be there. There has been a kind of pilot phase. I guess it's sort of still in that pilot phase where the software or whatever, which is being the front end of that software is a website being built by eBay, which itself has been very controversial among procurement people. But that system, in theory, is being tested, and the latest I've heard on it is that a sort of a slow, soft launch is taking place. However, it certainly hasn't been rolled out across the many thousands of organisations that really need it.
Thank you, Katie. I'm sure we'll be hearing much more about kind of PPE over the next weeks and months, and probably on next week's podcast as well. But just before we wrap up, I just wanted to come to you, Dave. You mentioned before that HSJ, you in fact asked a question in the government's press conference earlier this week, and I just wanted to pick up on one of your questions, which I think is one of our kind of most read stories this week, around the kind of concerns around a suspected new strain of, or some sort of strain of coronavirus that affects children. I've probably got that all wrong, but do you want to just kind of cover a little bit about what you asked and kind of the response?
Yeah, sure. Yeah, you're right. That is the concern. The story we'd broken that morning earlier this week was concern being shared among children's intensive care doctors, and concerns shared more widely with GPs about a presentation of symptoms which intensive care doctors were seeing in children growing over the last 2 or 3 weeks, symptoms sort of bearing some similarity to coronavirus, but in children, but not so similar that it would sort of be obviously that. And then they tested these unusual presentations, syndrome, as they potentially emerging new syndrome linked to coronavirus, as they described it. They've done tests, and enough of the children involved had coronavirus then, or had appeared to have had it in the past, that they are concerned that it's linked to coronavirus. Although there were some of these children affected, did not appear to have tested, did not test positive, so appeared to have not had coronavirus. So very confusing situation. I asked Matt Hancock and the Chief Medical Officer Chris Whitty and the NHS England Medical Director Steve Powis about it on the government daily briefing earlier in the week, and Matt Hancock's clearly said that he clearly taken some note of the issue and said that he was very worried, which is probably a sensible response to something which could seriously affect children in that way and is going to draw public attention. The Chief Medical Officer said that the experts are all looking at it. I think the Department of Health's looking at it, Public Health England's looking at it, and to a degree NHS England's looking at it to try and establish more facts. Chris Whitty, the CMO, said that his instinct was it could be linked to coronavirus, this new syndrome, because of the role of inflammation, sort of organs in it, which is common with serious bouts of coronavirus in adults. So that was his kind of instinct. Both him and Steve Powis, rightly emphasised the fact that it is still very rare, and that serious bouts of coronavirus in children are very rare, and I think the story, to me, the thing that strikes me about this issue is that it resonates with the kind of uncertainty and fear which are wrapped up in COVID-19, because clearly it's moved so quickly. Nobody has much certainty about this condition, this virus. Talking about coronavirus more generally, there's huge amounts of uncertainty about it. There's a lot of unpredictability about how it presents, even in adults. The symptoms can be pretty unpredictable, and although it mainly affects older people, there are people who seem to be seriously affected with no apparent kind of clear underlying reason for that. So there's unpredictability, and which creates the fear. I think people can't say, it's probably most conditions or things. You sort of understand your position and say, it's probably going to be other people who are affected, but it's harder to do that with this. So the idea that the one saving grace of it has been that a tiny number of children relatively are seriously affected, this sort of appears to threaten that one saving grace about coronavirus. But as they've stressed at the moment, it's a small number of cases, but clearly just needs to be seriously monitored. And I think that the reason alerts went out is because of the confusion around symptoms at the moment, and the concern, especially of paediatricians, that some parents are kind of thinking, I'll just stay away from hospital altogether, and being advised to stay away from hospital altogether. So they want to make sure people are sort of especially on the lookout for potentially serious symptoms, which actually they do need to go to hospital or get an ambulance. We seem to have lost Annabelle through a technical difficulty, so perhaps I will just I think we'd come to the end of our time on the podcast anyway, so on Annabelle's behalf I will just say thank you very much for joining us. Please subscribe to the podcast via Spotify, Apple, Google, etc., and please come back next week.